Okay, thank you. Please let me know if you can't hear me. All right, so goals today are to define and characterize CP, just a review, reviewing impairments affecting gait, describing classic gait patterns in cerebral palsy, and reviewing tone management treatment and orthopedic management in children who have cerebral palsy. So CP basics. By definition, CP is basically a static, unchanging lesion to a developing brain that results in some sort of motor dysfunction. And you'll see an image here. This is the most common brain imaging finding in CP. This is periventricular leukomalacia, which is seen in children who are born prematurely. This is not necessary for diagnosis. In fact, about 20% of children who have CP actually have normal brain imaging. But these are sort of the three characteristic things that define cerebral palsy. So that being said, it's a very heterogeneous group of children. We talk about CP and characterize children based on topography, meaning what area of the body is involved. So monoplegia being one limb, hemiplegia being half of the body, diplegia being the lower half of the body, triplegia, both lower extremities and an upper, and then quadriplegia, all four extremities. And you'll see in this picture there's a little bit of light green. Most of these kids have some sort of truncal involvement, and in particular kids who are diplegic, they typically have fine motor impairments, even though their upper extremities are not as involved. We characterize these kids also by their type of muscle tone or movement disorder, whether they have spasticity, dystonia, their functional levels, and that includes gross motor function, fine motor function, their swallowing, their communication, and then their etiology. So there are many different causes for CP, so prematurity, traumatic brain injury, infection, all sorts of reasons. And the reason why is these kids sometimes look different depending on what their etiology is. All right, so this is the gross motor function classification system, and I would say this is the most common functional measure that we use to describe children with cerebral palsy, both clinically and also in research. The manual abilities classification system is another that talks about upper extremity function, and then the CFCS, the communication function classification system as well. But the GMFCS is really important because it allows us to think about children with CP across their lifespan, because though this is a static lesion to the brain, we would expect it not to progress. CP is not progressive. There is a natural history to it. And so as children age, we see their function evolving. And so a child who's a GMFCS level 1 at the top, this is a child who's really functional. They're able to walk, run. They may not use any orthotics. They don't use an assistive device. They probably don't need a handrail. They don't need any handhold assist. So their highest level. The quality of their movements, though, might be different from that of a typically developing child. A child who's a GMFCS level 2, they might need a railing going up and down the stairs. They might need a handhold assist on uneven surfaces. They probably need AFOs or something like that to support them in walking. But still, they're very, very functional. Children who are level 3, these are kids who are, as they get older, primarily manual wheelchair users and are very independent manual wheelchair users. That being said, they can walk. They usually walk with some sort of assistive device, something like a posterior walker, and that gives them support. And this age group here in this picture, this is 6 to 12-year-olds. So a 2-year-old obviously does something very different functionally, and a 12-year-old does something very different, and an 18-year-old does something very different. So children who are in this level, GMFCS level 3, as kids get older, most of them choose to be in a wheelchair because their environment grows, they're wanting to do more things, they're wanting to keep up with their friends, and so they choose to primarily be manual wheelchair users. And sometimes this is hard for families to grasp. A child who's a GMFCS level 4, this is a child who is primarily an independent power wheelchair user, but who can walk short distances with something like a gait trainer, which is a little more supportive than a walker, and with assistance from an adult. And then a child who's a GMFCS level 5, this is a child who's completely dependent for all of their gross motor function, all of their functional mobility. So that's important just to think in the context of treatment of CP. Treatment is going to be very different depending on the functional level of the child. So I want to talk a little bit about gait. because gait is a lot about what we think of when we think about intervention. So these are the types of impairments that affect gait. So spasticity, this is just velocity-dependent resistance to passive range of motion. You hear about a lot of kids having spastic CP. Spastic CP is very common. Dystonia is also very common as well, and I think we're getting more and more interested in dystonia and appreciating it more and more and identifying it, therefore, more and more. So a lot of kids have a component of dystonia as well. Dystonia is a type of movement disorder. It's a posturing of an extremity. You can also see it in the trunk, the head, and the neck, and it results in an abnormal sort of movement. Oftentimes you'll see it in an extremity. It'll look sort of like this. When a child is trying to do something, voluntary movement increases dystonia, and so you'll see a sort of posturing that happens, and that, if you ever see it, is dystonia. Chorea is another type of movement disorder. These are large amplitude, jerky, dance-like movements. If you remember back to medical school, Huntington's chorea, these are sort of large, big movements. And then athetosis, these are sort of low amplitude writhing movements. All of these things can be seen in cerebral palsy. Hypotonia and, in fact, ataxia as well are extremely rare. And I always say, if you think that a child has hypotonic or ataxic CP, think of something else, because it probably isn't. It probably is some sort of other genetic disorder. So weakness is another impairment in children who have cerebral palsy, and this is important to remember in the context of some of the interventions that we offer. These kids have weakness to start. Some of the things that we do cause weakness, but they have a lot of weakness to begin with. Motor control is affected, so this is your body's ability to control your muscles in order to actually move your body in a certain way. So in order to do something like throwing a basketball, it requires a lot of motor control. Contractures are another impairment that we see in kids with CP. Contractures develop over time, oftentimes related to spasticity, dystonia, positioning, and these can certainly affect the way a child moves and functions. Rotational deformity is common, so femoral anteversion, this is just a twisting of the femur, or tibial torsion, a twisting of the tibia that results in kids walking oftentimes with their toes pointed in. And so you'll see a child with CP kind of walking like this. And a lot of that comes from the femur, sometimes it comes from the tibia, sometimes it comes from the foot, sometimes it comes from the muscles as well. All right, so now we're going to talk a little bit about gait. So normal gait. This is the normal gait cycle as we think about it. So you have your initial foot contact, your loading response, you're putting weight through your body, mid-stance, terminal stance, and then you're sort of preparing your limb to swing, pre-swing, initial swing, mid-swing, and terminal swing. And this is important because all of those impairments that we talked about can affect this. It can affect your walking. So for kids who have spasticity and they're walking on their toes, they're not going to have that initial foot contact of the heel strike. Their translation of their tibia through mid-stance is going to be different. So contractures affect this. Your ability to control your muscles affects this. So that motor control, all of those things have an effect on your gait. One of the most important things also about your gait are your 3 rockers of gait, and this is what moves you forward when you're walking. So your first rocker is your heel, and you can see you sort of roll over your heel, and that gets you moving forward. Your next rocker is actually your ankle joint, so your tibia translating anteriorly, and you can see that also sort of moves you forward. And then the last rocker is your forefoot, your metatarsal heads. So rolling over your metatarsal heads also propels you forward. And these are also things, the rockers of your gait, things that can be affected in children who have CP by all of those impairments. So again, if you're walking on your toes, you lose that first heel rocker. If we put you in an AFO that doesn't allow you to bend, you lose your second rocker. If we put you in an AFO that has a long sort of plastic piece that goes into your shoe, you're not going to be able to bend and get that third rocker. So some of the impairments affect gait, but also some of the things that we do as docs affect gait as well. This is a study by Graham and Rada. It's one of the sort of key studies in our population on spastic diplegic gait. We think of kids as sort of typically fitting into these 4 categories of gait. So true equinus is that really little kid who's just on their tippy toes, do, 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 do. They're very cute. And then you get this sort of jump knee pattern where the hip is flexed, knee is flexed, they're still plantar flexed. And you can see as I'm doing this, not only because of these shoes, but it's subsequently getting harder, right? Because I'm getting a little more crouched with each thing. Apparent equinus, even more crouched, such that the ankle is at 90 degrees, and then crouch gait, more like this. And that's really hard to do. If you try it, it's basically like doing a squat while attempting to walk. It's very hard, so it uses a lot of energy. And these are the common gait cycles that we see in children who have spastic diplegia. In hemiplegia, it's a little bit different, so one side of the body involved. Drop foot over there, type 1, that's basically a child who doesn't have the strength in their tibialis anterior in order to clear their foot, so they tend to drag it. True equinus, again, there's that up on their tippy toe. And then type 2B, recurvatum at the knee, that's a hyperextension of the knee that you see. And then that similar true equinus. And then type 4 is really important because it adds in the hip. So the hip is rotating, the hip is adducted. The reason why that matters is because kids with CP are at risk for their hips coming out and subluxing and even dislocating. In a child who's hemiplegic, you don't really think of that as commonly as happening unless they have this type of gait. If they have this type of gait, they're at a much higher risk for their hips coming out, specifically the one hip. All right, so we talked a little bit about GMFCS cycle, GMFCS level, we talked a little bit about gait cycle. Why does this all matter? As kids get older, like I said, they get taller, they weigh more, they have the spasticity, they have the dystonia. Maybe over time they've developed contractures and rotational deformity, and this all leads to bony deformity, joint deformity, gait dysfunction, and a change in their function overall. And that's where we see that natural history of CP in kids who are more affected, having this sort of decline in function when they get older because of all of these things. So what do we do about it? Now, there's some evidence in CP. This is a great article by Iona Novak from 2013, so it's not super up to date, but it's the only systematic review in cerebral palsy as it pertains to intervention. So we talk about spasticity management, what helps with that, contracture management, muscle strength, improved motor activities, function and self-care, communication, mealtime management, behavior and social skills, parent coping, and bone density. So those are all the things that we look at. They looked at in this study, and all the things that we think about when you're offering interventions to a child with CP. Why are you offering these things? What are they going to help with? And when you think about intervention, I always remind myself that you need to think about goals. What are the patient's goals? What are the family's goals? The reason that's important is because that can guide you in what you're recommending. It can also guide you in what sort of education you need to give. So if a child is a GMFCS level 5, they're totally dependent for all of their functional mobility, and family says, I'd like my child to be an independent walker. That requires a lot of education on my part that, that might not be a possibility, and this is why. But having those goals is really important to guide you in these other things. So tone management, how can that help them? Orthopedic management, and then therapy and orthoses. And we'll go through each one of those. So therapy, this is just a cute picture, which is why I included it. but involves obviously stretching is important, treadmill training, working on gait, all of those things that you think of that a therapist is doing. But what's the actual evidence behind that? So there's some evidence to support things like constraint-induced movement therapy, bimanual therapy. This is in kids who have hemiplegic CP, things like goal-directed therapy and home programs. These are important. And when a family asks me, can I get my kid into therapy? I always ask them, well, why? Like, what do you want to work on? What's your goal? Because you could do therapy 2 times a week for eternity, and it may not do anything to help you. But if you have a specific thing that you want to work on, like, I want to work on tying my shoes, that's great. And there's a lot more evidence to support that that is actually effective. Things like treadmill training may be effective, hippotherapy, pool therapy, neurodevelopmental therapy, I think everyone agrees we shouldn't be doing anymore. And then orthotics. So we use a lot of orthotics. Orthotics can help with passive stretching. Orthotics can help with gait. And there are many different types of orthotics and many different reasons why we choose different orthotics. So we try to be very thoughtful when we think about a child's functional level, their strength, their motor control, their high muscle tone, and how an orthotic can be helpful for them. Because there are so many different types. So this is a hinged AFO. It's a TAMI 2 brace from Cascade. And basically it allows that second rocker of gait. It allows your tibia to translate. So for some kids, that might be great. It'll allow them a little more forward momentum in their walking. For some kids who might not have enough strength in their plantar flexors, it'll just cause them to crouch. So there's a reason why and why not to use a brace like that. This is a 3.5. It has this posterior sort of leaf that's a little bit flexible, but not as flexible as this, so that might be another option. And this is just a solid AFO without that proximal strap. We tend to use this in kids who are little because they're getting up and down off of the floor. And so it's easier when you're able to actually move your leg in and out of that portion of the brace. So what is the evidence on orthotics? So as it pertains to contracture management, you should probably use orthotics, but remember function was one of the things that we think about, and it hasn't really been studied. So we don't have good research to support that orthotics help with function, but they can be useful for contracture management. So moving on to hypertonicity and movement disorder management. So we use a lot of enteral medications. We use baclofen, diazepam. Those ones help with both spasticity and dystonia. We also use Artane, Sinemet, and Dantrolene. Artane and Sinemet only help with dystonia. We don't use them for spasticity. Dantrolene is sort of, it's nice because it's peripherally acting of all of these medications. So it theoretically is less sedating. We use it for spasticity, and maybe it helps with dystonia as well. But looking at the evidence, there's maybe some support for diazepam. This is also based on very small studies that use diazepam at night. So this is for spasticity management, right? So it's not about function. So one of these up here was function. These things don't necessarily help with function, but they decrease your spasticity. So when I go in and see a child and I'm measuring their spasticity on the modified Ashworth scale, that decreases. But what does that mean for a child? We don't really know. Is it helpful? Parents say that it's helpful, but we don't have the evidence to support it. Chemodenervation and chemoneurolysis. So Botox, botulinum toxin, Botox is a brand, botulinum toxin basically causes chemodenervation. It prevents the release of acetylcholine into the neuromuscular junction, basically stopping the contraction of a muscle. So we like that because it's useful in treating spasticity and dystonia. But we're actually learning more and more now about repeated use of Botox, and that it can actually cause some fibrosis and scarring in muscle. And so I think for a lot of us, our practice has changed, and we're maybe using Botox less and less in this population as we're learning more and more about it. But it has been studied to be effective for spasticity and maybe for improved self-care and function. Phenol is a little bit different. may not be something that many of you are familiar with. It's a really old medication. It's really cheap, and so people don't study it because nobody has incentive to study it. But we use it for chemoneurolysis, which is basically killing the nerve. It basically causes Wallerian degeneration of the nerve, which can reduce spasticity and dystonia. It is, like I said, it's very cheap. It lasts a lot longer than Botox, lasts 6 to 12 months, which is great, but it has to be done in the operating room under anesthesia because it's really painful. So if you look at evidence, like I said, there's really not a lot of evidence to support its use. Baclofen pump. So baclofen pump is an implantable device that is implanted in the belly. The catheter, all underneath the skin, goes either into the spinal fluid in the back, or we're actually implanting intraventricular catheters now into the ventricles of the brain. And this helps with sort of global tone management, that's what we call it. So spasticity and dystonia throughout the whole body. We're using the intraventricular catheter placement now for treatment of dystonia, theorizing that if you're putting the baclofen directly where it's acting, dystonia, when we think, comes from involvement of the basal ganglia, the cerebellum. If we're putting the baclofen right there, is it more effective? And I think we don't really know yet. But baclofen pumps can be wonderful. We do have evidence to support the use of baclofen pumps. It's not great evidence, but in terms of spasticity management, it can decrease spasticity and maybe can improve function in self-care. What they didn't include in this study is dystonia, and there actually is some research to support that intrathecal baclofen pumps can decrease dystonia as well. So that is an option. Another thing is something called a selective dorsal rhizotomy. And to talk about that, we kind of need to just review the stretch reflex. So taking it back to like pathophysiology of med school, if you stretch a muscle, it sends an afferent signal, sensory information, into the spinal cord. That information is then modulated by interneurons. These interneurons are receiving information coming down from the brain, and then there's information that's going out via efferents and telling the muscle to contract. So that's a stretch reflex. So with selective dorsal rhizotomy, with spasticity, first of all, there's a loss of descending inhibition, right? So basically, this information coming down from the brain that's telling this interneuron, oh, hey, don't worry about that stretch reflex. You don't have to, get all tight, telling the muscle that. That is lost. So what happens in spasticity is then this response is heightened, and the muscle is overactive. And so with selective dorsal rhizotomy, what the neurosurgeon does is they cut that dorsal nerve, or a portion of that dorsal nerve, decreasing the sensory information coming in, therefore decreasing and getting rid of the spasticity that is a result of that loss of descending inhibition. So that's sort of how SDR works. The selection criteria for SDR, typical age is about 3 to 8 years old, and there's a reason why kids who are younger, they're making lots of changes, they're developing rapidly, so we try not to do any big, huge interventions. Kids who are older, they've developed these motor patterns over time that are really difficult to retrain. We're looking for a child who's strong enough, who has good enough motor control, who actually has spasticity and does not have dystonia. Selective dorsal rhizotomy does not treat dystonia. And so that's important to think about. And then also participation. After doing a selective dorsal rhizotomy, it completely gets rid of spasticity, and so the child is very different. Their body is very different. They have learned to walk with all of that spasticity. When you get rid of it, they stop walking. And so they have a pretty significant functional decline, which is expected. We know that it's going to happen. We prepare families for the fact that their child is not going to walk. And then they slowly work on retraining that walking over time. So participation is really important. This is just an example of the surgical procedure. They do a single level laminectomy, and then they're isolating specific nerve rootlets that are dorsal and that are for target muscles. They use neuromonitoring to see which muscles they're stimulating with the stimulators. So SDR, it decreases spasticity. We're pretty confident in that. It maybe improves function in self-care. Most of the studies on SDR are actually on gait biomechanics, which it improves. There's some new research on motor control. It doesn't improve motor control over time, we now know. And that's based out of the gait biomechanics lab at University of Washington. So I wanted to go through a couple of cases because cases are always more interesting. So this is a 4-year-old boy who has a history of 30-week prematurity, cystic changes on his imaging. He's a GMFCS level 3, so he reciprocally crawls, he ambulates with a walker, is independent with transfers on and off the toilet and to the walker, and uses a manual wheelchair for distances. On his examination, I kind of highlighted the things here. The popliteal ankle, that tells you about hamstring tightness. So this is a child whose hamstrings are a little bit tight, ankles are a little bit tight, definitely has spasticity. This is on the modified Ashworth scale. It's a scale out of 4, obviously. So the hip adductors, 3 out of 4 in the hip adductors versus the abductors, quads and ankle dorsiflexors, hamstrings, plantar. So lots of spasticity, basically. Remember, that's one of the things that we're looking for. And then this is a kid who's actually fairly strong. And this was his gait video. So this is him pre-SDR. This was our initial evaluation. So he's walking with that toe-toe pattern. And he's in sort of that jump knee pattern, right? His knee is flexed. He's using a posterior walker to walk. He's sort of crisscrossing and scissoring a little bit, so that can tell you that the hip adductors are tight and have some spasticity. And now once you take away the walker, you can see still it's very difficult for him to walk. Some of that comes from weakness, some of that comes from impaired motor control, and some of it comes from the spasticity itself. So we recommended for this child a selective dorsal because he was pretty strong, had good isolated motor control, he had a lot of spasticity, we didn't see any dystonia, and he had great rehab potential. He had intensive inpatient rehab post-operatively, and across the country, there's a lot of practice variation after selective dorsal from no rehab to 3 months of inpatient rehab. Ours is somewhere in the middle, where we do about 3 to 4 weeks of inpatient rehab, followed by pretty intensive outpatient therapies for the next year. So this is him post-SDR, 1 year post. So you can see his assistive device is a lot less restrictive. He's walking with Lofstrand crutches now, and he's able to get that sort of foot flat. He's not as high up on his toes. Some of that comes from motor control distally and strength. Most of these kids, they might have good isolated motor control at the hips and knees, but at their ankles, they're very limited. And that's okay because we can put them in AFOs, and that can help to control him. But even now, without the Lofstrand crutches, he's able to walk. So I think this was a very positive outcome after the selective dorsirhizotomy for this child. All right, now let's talk a little bit about orthopedic management. So contractures, that was one of the impairments that we talked about. Contractures we can treat sometimes with Botox just to relax the muscle. Oftentimes we'll pair it with serial casting just to get the range of motion back. You can do that when kids are little. Once they get to be at about 10 to 12 years old, it's not very effective anymore. And so we typically see in kids who are younger, we're doing more Botox, maybe casting, and then as they get older, we're doing more surgery for contracture release. The reason why, for certain muscles, the gastrocs in particular, if you do surgery before age 7, we know that kids tend to require a second surgery. So oftentimes we'll try to put that off as much as we can so that they require 1 surgery. And I think that this probably will change as people are using less Botox. So this is how orthopedic surgeons used to manage contractures in kids with CP. Mercer-Rang is an orthopedic surgeon who coined this term birthday syndrome. What they used to do is basically a surgery every single year in order to improve a child's gait. So a child is walking in equinus, so they do a tendo Achilles lengthening, and oh boy, their hamstrings were tight, so let's lengthen the hamstrings. Oh, their hip flexors were tight, let's lengthen the hip flexors. Oh, their rectus femoris is firing out of phase, and so they can't bend their knee during gait. Let's do a rectus femoris transfer. And then finally, this poor child is able to walk better. And so this means 1, 2, 3, 4 surgeries, 5 surgeries, sometimes more depending on the severity of a child, and 4 or 5 recoveries, 4 or 5 rehabs. And that's a lot. That's a lot for a family. It's a lot for a child. And so what they eventually developed was something called the single event multi-level surgery, or SEMLS. And so what the SEMLS is basically they do everything at once, right? So they do all of the tendon lengthening procedures, whatever a child would need, whether it's lengthening their gastrocsoleus, doing that rectus femoris transfer, lengthening the hip adductors, the hip flexors, and then they're also addressing bony deformity. So we talked a little bit about that femoral anteversion, the twist of the femur bone. Sometimes they'll do a derotational osteotomy for that. Same with the tibia. Sometimes in kids who are a little bit older, they have foot deformity. So all of this surgery they end up doing in one surgical setting. It's a big surgery, but kids do very well after it, and it means one rehab in terms of sort of a decline in function that happens after a big surgery, doing lots and lots of therapies, and eventually getting back to where they were, and hopefully even better. And after a surgery like this, we think of it as being about a year before they get back to where they were pre-op, and then hopefully getting stronger and better over time. So this age, it really depends on the child. Some things, soft tissue lengthening, we'll sometimes do earlier. So when kids are little, we like to wait as long as we can, because then, again, we're less likely to have to repeat a surgery, because as kids grow, they go through growth spurts and they get tighter. The bones are growing quicker than the muscles are, and so as they go through these periods of growth, they get tighter and tighter and tighter, and so that's why we try to wait. So I've seen for soft tissue lengthening, maybe 4 years old as the youngest. More typical is probably around 10. If you wait too long, then sometimes you end up with more bony deformity. If you wait too long, then, for example, the hamstrings might be so tight that the neurovascular structures have shortened, and so you can only lengthen them so much. So there's sort of a fine balance in terms of when to intervene. All right, so we have 2 SEMLS cases. So this is a 5-year-old, 30-week prematurity, GMFCS level 3, similar to the other child who we saw. And for time's sake, we'll go through, I highlighted a lot here, you can see, so lots of contractures in the hip flexors, hip adductors, and the hamstrings. The knee joint, in fact, is also contracted, and in the ankles. And so this is a child who had just soft tissue lengthening. So she's 5, remember? And this is the video for her. The pre-op video is on the left, and the post-op video is on the right. And remember, obviously, these surgeries, the SEMLS surgery in particular, it lengthens the tendons and muscles, right? It doesn't change the motor control. Oftentimes it makes kids weaker because you're cutting through muscle, and so they're initially weaker after the surgery. And so her walking isn't going to be perfect, but you can see that her range of motion is better. She's not so high up on her toes because she has the length to actually get her foot flat. She's able to extend her knee a little bit better. And you can see she's actually more efficient in her walking as well. All right. Yeah. Kids actually are really resilient, and they do great. These kids who have the SEMLS and who have the selective dorsal-rhozotomy when they're very young, they do wonderfully. A lot of them, actually, when you put them in a wheelchair, they have a great time. They love it because they have this new form of getting around, and they're really fast because a lot of these kids have really good upper extremity strength. And so they actually do great. I think the parents struggle with it, and the parents struggle with it, I think, more when a child is older, just because when they're dependent, if they need help with transfers or things like that, it's a lot harder to dependently transfer a child who's 10 versus a child who's 5. So for some reasons, the younger kids actually do better. So this is an 8-year-old, so an older child, IVH on her initial imaging, GMFCS level 3, but you can see functionally she's a manual wheelchair user in the community. She's had a lot of prior interventions, therapy, baclofen, serial casting, Botox injections. She also has a lot of contractures in the hip flexors, hip adductors, hamstrings, the knee joint, and the ankle plantar flexors as well. So she had both a soft tissue lengthening surgery in all of those areas, adductors, iliopsoas, hamstrings, Achilles, and peroneus brevis, but also had bony surgery. So she had a bilateral calcaneal lengthening in the feet. So this is her pre-op on the left. So you can see she has that sort of crouch pattern. So she's crouched. She's using a ton of energy to stand and walk. Her ankles are in dorsiflexion due to the change in structure of her foot. Her knees are flexed, hips are flexed, and it's just really hard. It's really hard for her to walk. She's using 2 quad canes to walk. And then post-op, you'll see without AFOs, she still has a lot of weakness. Right? But with her AFOs, she no longer needs an assistive device. She's able to stand upright. She's taller, right? Because she doesn't have those contractures. She's still a little bit toe-toe in terms of her initial foot contact, so she doesn't quite have that heel strike. They may not have been able to fully get that range of motion back given how tight she was. But she's a much more independent ambulator here, and her walking is so much more efficient. It's so much easier for her, so it's easier for her to go longer distances because it's not so much work and not as much energy. But I think this is a good point. When you take her out of her AFOs, she's still in that sort of crouch position, and so a lot of that is weakness that didn't change with the surgery, or even if initially would get worse. So, in summary, we talked about impairments affecting gait. We talked about hypertonicity and movement disorder, weakness, motor control, contracture, rotational deformity. All of those things affect your walking. We talked about the typical gait patterns in diplegia and hemiplegia. We talked about intervention based on goals, therapy, bracing, tone management, and orthopedic management, and how those things can be effective. So, thank you.